Good afternoon, everyone. Welcome to the second series of the Gender Mainstreaming and Social Inclusion Webinar Series with AISE Consulting. I'm pleased to have an excellent group of panelists with us today. I'm going to briefly introduce them and then leave it up to them to introduce themselves. So today we're having an exciting team who are going to talk about different things. They're going to talk about their experiences in working on sexual and reproductive health with the UN, and that will be led by Mr. Niyi Ojuolape. And then we're also going to have experts from the London School of Hygiene and Tropical Medicine, as well as from King's College London, sort of go through their experiences working in humanitarian settings, especially mainstreaming gender and social inclusion. Then we're going to have Deborah Delgado. I hope I pronounced your name well, properly, Deborah. Yes. She's going to talk about her experiences working on climate change and conservation in the Amazon basin. And we are going to have Dr. Annie Hoops, a consultant pediatrician working with Kaiser Permanente, talk about her experiences on adolescent sexual health. I'm going to do a very quick presentation to sort of run you through their topics and expertise, and then I will let Mr. Niyi Ojuolape start with his presentation. I'm just going to quickly do that. Okay, great. So, this webinar series started from, and we noticed at AISE Consulting that a lot of interventions were being done in different fields. And though you had a response, you had different academic institutions and also UN organizations asking for gender mainstreaming. This was specifically in certain components of health intervention. And we thought, it would be useful to bring together learnings across different thematic expertise and to sort of talk up more about social inclusion and intersectionality. And these are just a few to give you an idea of several things AISE Consulting works on. A few slides, which I will quickly speed through. So we work on gender mainstreaming and analysis, inclusive education, health system strengthening, gender-based violence, conservation and climate change, and development. And one of our key goals is to sort of provide evidence base for ensuring gender mainstreaming, social inclusion, and health system strengthening and development in low and middle income. So you probably might have attended our previous webinars, but if you haven't, for this webinar, we're going to be, some of our speakers are going to be Mr. Niyi Ojuolape, who is UNFPA's resident representative in Ghana, Dr. Neha, who is the co-director of the Health and Humanitarian Crisis Center and an assistant professor at the London School of Hygiene and Tropical Medicine. We have Ms. Kristen Mega, who is at King's College London and works on the research for health and conflict in the Middle East. Dr. Deborah Delgado Pogli, who is an associate at AISE Consulting, a principal investigator and assistant professor at the Pontifical Universidad Católica del Peru. And then we have Dr. Andrea Hoops, who is a consultant pediatrician based at Kaiser Permanente. And I'm going to quickly go through their backgrounds and profiles, but I will also let them introduce themselves. So Dr. Niyi is currently the UNFPA's resident representative in Ghana. He's also worked at United Nations UNFPA's chief of staff at the headquarters in New York. He was also a former special assistant to the executive director at UNFPA in New York. Before joining UNFPA, Mr. Ojuolape served with the Nigerian government in different capacities, including as a special assistant to the Minister of Health and the chief program officer for donor coordination for the Nigerian National Agency for the Control of AIDS. Mr. Ojuolape holds a Bachelor of Science degree in Banking and Finance. Sorry, I skipped that. And as well as an MBA. The second speaker, Dr. Neha, is the co-director of the Health and Humanitarian Crisis Center, as I said before, and she has a diverse background in public health with expertise in health policy and systems research. Neha also led a commentary piece, which we'll be talking about, which sort of shared some of her findings on intersectionality, mainstreaming gender, and intersectionality in responses, COVID-19 responses in humanitarian settings. She regularly works with several UN and international organizations and governments, and she's a technical advisor to the World Health Organization. Christine, a colleague of Neha, also worked with her in the commentary piece they'll be talking about. She works at King's College London in the Conflict and Health Research Group. She also leads a Women's Leaders in Health and Conflict initiative, which sits within these programs. Christine has also started her PhD at King's College London, which investigates the role of women's leadership and participation in health system strengthening in northern Syria. Prior to working at King's, Christine has also worked with the New Zealand government, the International Organization for Migration, and NGOs in Australia. Dr. Deborah Delgado is a principal researcher and assistant professor at the Pontifical Universidad Católica del Peru. She has extensive experience as a consultant and researcher in environmental governance and climate policy. She also recently won a grant to work with Indigenous women in the Amazon basin and to sort of see what their responses are during the COVID-19 pandemic. She has also been involved in a lot of policy advocacy processes, and she has followed the UNFPA processes as a multi-skilled agenda. Dr. Andrea Annie Hopes is a board-certified pediatric consultant, adolescent medicine physician. She practices with the Adolescent Center at Kaiser Permanente. She is also a researcher and conducts several research projects on adolescent health. She has participated in clinical and policy level advocacy efforts to improve health services and sexual health education for adolescents in the United States and in low middle income countries. She has also done some work for the World Health Organization. So we are very excited. We're very excited to have this team of experts. And now I am going to let them lead, starting with Mr. Niyi Ojuolape, who's going to talk about some of his experiences mainstreaming gender and social inclusion. Thank you.
Thank you very much, Doctor. Let me share my screen. How do I share screen? Yeah. Okay. Let me first do a sound check to see if you can hear me, Doctor.
Yes, I can hear you.
Okay.
Great. Thank you.
Let me do F5. Okay. So the topic is mainstreaming gender and social inclusion in COVID-19 responses. And we have a very, very unique case in Ghana. Not particularly unique, but then it's unique in the sense that with which the government took the response at the beginning. Now, the introduction, by way of introduction, I would say the pandemic, it's a global pandemic, and as everybody knows, it came along, apart from the health implications, there were also very, very serious socio-economic implications everywhere, not just in Ghana. But for us, we look at it, we see it for those of us in UNFPA, United Nations Population Fund, by the way, if I may, we are very, very interested, in the issues of gender and in gendered implications of anything that happens within the country. And so when the pandemic hit, we were looking out for the implications as to gender in terms of from the gender lens. And so we had the first case in March 2020, and thereafter the government came into the arena to respond very, very positively to the issue of the pandemic. And government actually brought in $100 million to invest in combating the pandemic. So every aspect of the health sector requirements was taken care of. There was testing provided. There were several other things that government took care of in terms of treatment, isolation centers, health sector workers, personal protective equipment, and everything. Government made sure to provide everything. But we in UNFPA, we noticed a gap in the response. And that is the socioeconomic response to the pandemic, which we saw had a gap in the gendered implications. What is the implication for women? What is the implication for gender equality? What is the implication for gender equity? We noticed all that. And now we can see, I can tell you that when we noticed that, we came into the arena to bridge this gap. And over time, you can say that the president has shown a manifest interest in all that is happening. I can say probably that will be the only president in the world that has addressed the nation. Solid addresses for 17 times since the pandemic hit. And government put a lot of money, and there was also a lot of facilities that was put into it. Now, what does the coronavirus, what is the implication of the coronavirus pandemic on the populace? It has several negative effects. You will see that it had the extreme poverty. There are people in extreme poverty, but then it has also increased the number of people in extreme poverty by 9.1%. The coronavirus pandemic also has caused 65% of this increase as a result of the fact that we had lockdowns in the country, in the society. Also, we have excuse me, we have confirmed cases, credible data that shows that savings of 30% of the population will vanish as a result of the pandemic. Now, what does this mean in particular for vulnerable women and girls? Those, the effects of the pandemic on the general populace, that is already well known. But then for us, if we look at it, what does it mean in particular for women and girls? First, there will be deepening gender inequalities, and that was noticed right from the beginning. Secondly, is the fact that because there is little or no social security or protection within the country, the poor suffer more. Apart from, so we have the women, they suffer more, the poor suffer more. So you can take it from there that the poor women are actually at the bottom of the ladder, and they are the ones that will have the COVID-19 pandemic affected the most. And thirdly, which is the third part, which is very, very important, which also accentuates the first two, is the issue of sexual and gender-based violence and poor reproductive health outcomes. Those are facts that are staring us in the face, which anybody, if you just take a somber look at the pandemic's effect, you will see that these are very, very important issues that we need to that needs to be tackled. But resources and attention was not coming appropriately, adequately from government to look after it. And so for us in UNFPA, we got involved in the COVID-19 response by looking after this particular issue. So, and we decided that in line with the UN mandate, which is to build back better, we got involved. And then, what are the measures that we took in order to tackle the issue of sexual and gender-based violence and the gender implications of the pandemic? First, we had to go to town to let everybody understand that there is the issue of domestic violence, because as soon as the virus hit, A couple of weeks after, the president, the government had to lock down the country to say everybody should stay in their homes. And if you see, for those who are living with aggressive partners already, or those whose intimate partners are domestic violence perpetrators, that increases their risk, and also that puts them in more danger. And so the first thing we did was to ensure that we created an advertisement, a publicity campaign to talk about the possibility of domestic violence and the implications of domestic violence, and to let people to understand that in cases whereby you have domestic violence, what are the things that you can do while being locked down in the same space as your aggressor. So we established the domestic violence hotline. We now call it helpline. The domestic violence hotline, with which people should be able to make a call, and when you make a call, there will be some form of either help or some form of response from the special police unit that looks after the issue of domestic violence. In Ghana, that unit is called DOVSU, that is Domestic Violence and Victim Support Unit. So we activated that helpline, and it's 24/7, and calls were coming in, reporting cases, and we're able to respond to those cases by transferring them to DOVSU, and DOVSU they did their best in reaching out to those that are involved. That is the first thing that we did. But secondly, like I said, we went to town. Going to town means that you need to get people to understand what their choices are concerning sexual and gender-based violence and domestic violence. And in order for the publicity to get enough traction, we did a multimedia campaign, which included bringing in people, social media influencers, not just social media influencers, but influencers in the society, those who have a large following on the internet, on Instagram and what have you, so that the word can be spread around. So we engaged actors, we engaged actresses, artists, musical artists and what have you, and we use them, we use what they have we use their platforms, their Facebook, Instagram platforms, Twitter platforms, to send out messages, to say something like, if your partner is aggressing you, or if you are facing domestic violence in any form, please call this DOVSU number. Help will come your way. And it actually had a lot of traction, because all over the country, people got to know that they had choices when such things happen. And the third prong of that multimedia campaign was that we sent out text messages. We sent out text messages to individuals generally. We sent out about 1 million mobile phone users, so that they have the information about what they can do, and also how to call the helpline, for them to understand that gender-based violence should not be accepted in the society. And that gained traction. We got a lot of responses. And so the next thing we did, as you will see, is that we had several, because nobody could go out. We had captive audiences in the houses. So we had several e-workshops, virtual workshops, to talk about the issues that are involved around sexual and gender-based violence generally, and to also bring on board several other people that will add value to the campaign. Another major thing that we did was we already have within Ghana, we already have some shelters for women. That is where women can shelter when they are with abusers and they realize that their lives are in danger. So we had some shelters which were in a state that needed some renovation. So we rapidly moved into it to renovate those shelters so that people can be able to take advantage of it. Also, we used to have with our colleagues in the UN, the colleagues in IOM, they have the human trafficking shelter, which is for those who are being human trafficked. So we also talk to them, and with the government, with the Ministry of Gender, for us to have their shelters repaired and being ready to take on those who might need it at the end of the day. And the other things that we did, the other interventions that we in UNFPA that we carried out, was to provide what we call dignity kits. Dignity kits, basic essential items that a woman, usually a woman will need to be able to maintain her dignity in any circumstances. So you have this pack that that includes washing soap, bathing soap, a towel, toothpaste, sanitary pads, and just basic things, a box of pomade, and certain things that everybody will need in order to live a life of dignity. I mean, on a typical day, just the most basic. Actually, for us in UNFPA, this is what we actually provide in humanitarian conditions and in war situations generally. But then the situation in which we were as at that time was that women who are generally vulnerable needed that, because they are not, those women, their subsistence, the vulnerable women that we targeted at are such that they live on a day-to-day basis. They live on what they get per day. And during that time, during the time of the lockdown, during which they will not be able to earn any living, we had to parachute this across to them. But we gave them dignity kits, not just to serve as handouts, really, but really to use that as an entry point in order to give them reproductive health education that will enable them to carry out actions that will enable them to maintain their dignity, and also to understand what they can do in cases whereby problems arises, problems that has to do with sexual and gender-based violence. So we gave them, and we also went to isolation centers. We also gave out dignity kits to them. We searched out people living with HIV, people with disabilities, and even some people who are in hostile institutions. We reached out to them with hygiene products. You see, we also ensured that talking about the issue of COVID-19, that it included hand sanitizers, it included soap, toiletries, and basic things, and face masks, so that while maintaining their dignity, they can also do their best to ensure that they are not that they don't come into contact with the virus. Now there is a set of most vulnerable women in Ghana, which are called the Kayayes. The Kayayes are the head porters. You usually find them in markets. So I mean, somebody goes to the market, buys his or her stuff. You have these people who come around you to say, I will help you to carry your stuff from where you have bought it to where your car is. So they help people like that, and so they get pittance from those who they help. And so these are there are, and those who are among these. I mean, the chief among these sets of people in Ghana, which we call the Kai, they actually migrated from the north, came into urban centers to try and eke out a living. So they are vulnerable, and most of them, they don't have shelters. Believe me, they don't have shelters. They don't have where they stay. They actually sleep outside in the elements, and they don't have shelter. They are very poor, and so by virtue of that, they are vulnerable to all sorts of things. They are vulnerable to gender-based violence. They are vulnerable to rape. They're also vulnerable to sexually transmitted infections. So these are a particularly catchment set of people. So that particular cohort, we knew that we had to reach out to them, because they are also vulnerable to unintended pregnancies, especially if they, for most of them that are actually illiterate, and so they needed reproductive health education to get them to understand that because you see them, their children, they are also carrying children. That means that they actually had unwanted children, so they carried unwanted pregnancy. So we needed to reach out to them to stem the tide of teenage pregnancies, which is very, very rife among them. So the period of the COVID-19 also enabled us to get them as a captive audience to give them reproductive health education so that they can do what they need to do. Now, one other thing that we did, as you can see from my presentation, is that we have a group of young people within UNFPA Ghana, and their networks also. So we did door-to-door campaign. Door-to-door campaign, taking along the commodities, contraceptives, the condoms, and what have you, and also the domestic violence pamphlets and information booklets to give it out to people and answer their questions and respond to their needs. And in doing this, so Yole Fellows and the interns, they went out and we were able to reach thousands of families just by that door-to-door campaign. Now, I've told you about the AISE. We instituted as a result of COVID-19, and even this actually started after the period of the lockdown. We instituted a program which we call CASPRO. CASPRO is a KIA assistance project. So we started this project, and we got a cohort of 500 young ladies, because most of them are actually adolescents. 500 young ladies. We brought them together in order to respond to the risks and vulnerabilities that they face as a result of the issues of dignity, theft of their sales, harassment, rape, sexually transmitted infections. They also engage in unsafe abortions and unintended pregnancies, which came out of it, and all sorts of things, and also HIV. And so, so we decided to focus on them and attend to them. So what we did, which we call connecting the dots, was to find a way in which we'll respond, we'll give them what they need. That is the basic things that they require in order to, and we use that as an entry point to give them reproductive health education. We give them essential relief items, the dignity kits that I mentioned, that I described much earlier. We also give them sexual and reproductive health education and information on services. When we enroll them in a mentoring program whereby they get mentored by individuals in the society. And then, very importantly, we will not let them just go away like that. We have what we call the entrepreneurship and income generating activities, in which we teach them, we give them basic vocational training about what to do, beads making. So they took, whatever they are comfortable with. Some of them are now making pastries, some of them are making, doing beads, some of them are doing weaving and what have you. Then very importantly, we must also note this, because in doing this, if you give them food, we don't have shelter to give them. If you give them food, you give them mentoring, you give them entrepreneurship and vocational training. We also needed to guarantee their health. Therefore, we enroll them on the National Health Insurance Scheme so that they can have access to health. So basic opportunistic infections and what have you that comes, they are able to take care of it. And so we have found it very, 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 very wonderful, because the results that have come out of this, the people who are involved over time, they've matured, especially based on the reproductive health education that we give them. So what are the lessons learned? What pointers can be taken from our approach? You will see that our approaches are actually community-centered and they are solution-driven by even the beneficiaries themselves. We have also learned that the use of digital platforms during the period of COVID-19 have proved very, very useful in reaching very large groups of people. And we have also realized that another lesson is that the awareness creation and education programs are best received in local languages. When people have it in their local language, in their mother tongue, they are more likely to understand and take it on board and use it. And their interventions also, our interventions also show that you should leave target beneficiaries empowered and not even more dependent. So when you give them the handouts, you should find a way to make them to be able to fish rather than just taking fish from you. And we also find out lastly that interventions and activities should be tailored to specific target groups so that your interventions are tailor-made, and we should note that no one size can fit all. So I want to thank you very much for your audience. I'll be able to take any questions whenever you want me to. Thank you very much, Doctor. Over.
Thank you very much, Mr. Ojuolape, for that wonderful presentation. I'm just going to ask you to stop sharing your screen. Okay. No. Yes, thank you. Thank you very much. It was really interesting to hear you sort of highlight UNFPA's responses that were not just specific on gender-based violence or empowerment of migrant women, but really took a more holistic approach. So sort of targeting different ways that you can empower them and make them safe, and also give them access to help during the COVID-19 responses. We're going to have a question and answer session immediately after all the presenters have finished. I would like to encourage the participants to please go to the Q&A sessions there's a question and answer chat. Please pose your questions there for Mr. Niyi Ojuolape. He'll be available to answer some of these questions regarding his presentation and UNFPA's work in Ghana shortly. Our next presenter is Dr. Neha. She's from the London School of Hygiene and Tropical Medicine, and she'll be sharing some of her experiences mainstreaming gender and social inclusion in responses in humanitarian settings.
Thank you. Hi, everyone. Today, my colleague, Kristen Meager, and I are going to talk to you. I'm afraid we don't have a PowerPoint. We thought to be more informal, but we're going to talk about the role of gender-inclusive leadership during the COVID-19 pandemic to support vulnerable populations in conflict settings. And this is based off a commentary that we wrote along with Dr. Preeti Patel, who I believe is also on this webinar that was published in BMJ Global Health. And I'm just popping the link to that in the chat box now, in case you'd like to read further. But just to start, at the end of 2019, the United Nations High Commissioner for Refugees, or UNHCR, reported that an unprecedented 80 million people were forcibly displaced as a result of persecution, conflict, generalized violence, or human rights violations. And this number has almost doubled since 2010. Forced displacement is now affecting more than 1% of humanity. So that's 1 in every 97 people. And with fewer and fewer of those who flee being able to return home. 5 countries account for 2/3 of people displaced across borders: Syria, Venezuela, Afghanistan, South Sudan, and Myanmar. With COVID-19, the pandemic is overlaid onto already extremely volatile environments where conflict and humanitarian emergencies intersect. So who are vulnerable populations in these settings, and what happens in humanitarian settings to disrupt gender norms? We know that women are disproportionately affected by conflict and humanitarian emergencies. So of the 80 million I mentioned who are forcibly displaced at the end of last year, 3/4 were estimated to be women, adolescents, and children. Conflict promotes conditions during which existing gender inequalities and inequities are amplified. Community structures, access to healthcare, and human rights are all compromised, resulting in worsening conditions for women. Health consequences of conflict also disproportionately fall along gendered lines, resulting in high rates of maternal and neonatal mortality and morbidity and sexually transmitted infections. This growing evidence base demonstrates excess female morbidity and mortality and reflects the necessity of evaluating the role of women in leadership, driving health research, policy, and programmatic interventions in conflict-related humanitarian contexts. Furthermore, this domain of conflict and humanitarian health also uniquely positions itself in non-permissive and often highly securitized and politicized contexts in which attitudes and assumptions toward leadership are predominantly male-normed and rooted in colonial legacies. Over to Kristen.
Great, thank you for that, Neha. Hi everyone, and it's wonderful to be here today. So I just wanted to highlight specifically our commentary as well, and why we wrote this commentary. Because there's been a significant amount of attention that's been given to women political leaders in high income settings, where it's been reported that women have led several countries' effective national responses to COVID-19. And we really wanted to highlight through our piece that cultivating and harnessing the advancements of women's leadership globally and implementing a gender-inclusive lens in pandemic preparedness and responses by including the experiences and voices of women in conflict is paramount, because it is extremely difficult to mainstream gender-inclusive policies in these settings, which we'll discuss as we go through. So the rationale behind this is that it will in turn create effective leadership models, as well as improving women and girls' access to adequate healthcare in humanitarian and armed conflict settings. So as Neha mentioned, women and girls are disproportionately affected by armed conflict and humanitarian emergencies. And this disproportionality has been exacerbated during COVID, where in conflict settings, we're seeing that one of the most affected and at-risk population groups include women and girls who lack decision-making power. During a pandemic, we see that resources for and access to adequate health services are further complicated. Of particular concern, resources to deal with the pandemic, as evidenced during Ebola and Zika, for example, are often diverted from essential health services for women and girls, so namely sexual and reproductive health, which has lasting effects for themselves and their communities. Previous public health emergencies have shown that the impact of an epidemic on sexual and reproductive health often goes unrecognised, because the effects are not often the direct result, but rather the indirect consequences of strained healthcare systems, disruptions in care, and redirected resources. We do know that sexual and gender-based violence also increases during humanitarian crises, and access to support services are frequently halted or disrupted during pandemics. The International Rescue Committee has found through its analysis of gender-based violence that the suspension of these protection services for women, restrictions on mobility, lack of information, and increased isolation and fear have resulted in a dramatic drop in the number of reported cases of violence against women and girls in conflict and humanitarian settings. And of particular concern, we see Syria, Iraq, and Burkina Faso, for example, as the ability to report violent incidences are removed. Now, we also know that in these settings, testing capabilities for COVID are extremely challenging in resource scarce settings, many of which are affected by conflict and other humanitarian emergencies. A report again from the International Rescue Committee shows Yemen, Chad, Nigeria, Mali, and northern Syria are of particular concern with low testing numbers, which highlights the dangerous prospect of undetected and uncontrolled COVID outbreaks. But it also points to an even greater lack of access to testing and healthcare for women in conflict-affected settings. So despite their increased exposure to the disease as primary caregivers and healthcare workers. Also, the policies that have been implemented as a result of COVID reveal significant gendered impacts, and these are exacerbated in these settings. So policies of social distancing, self-isolation, hygiene measures, increased use of personal protection equipment. All of this is very resource intensive and difficult, if not impossible, to implement in many settings, particularly in refugee camps. So building on this, I wanted to discuss a bit more around Syria. So the current conflict in Syria provides an example of the difficulties of gender mainstreaming in COVID responses. As we have discussed, conflict disrupts community structures and gender norms. So in Syria, for example, prior to the conflict, some areas, particularly the major cities, there were more enablers for women to balance family and work. There were support systems embedded within culture, which with extended families providing support, for example. However, the conflict has fragmented families and communities, increased religious conservatism, and damaged family support structures, which creates an environment in which patriarchy increasingly thrives. Religious conservatism has been increasingly manipulated to preserve the traditional female role as a homemaker, contributing to increasing numbers of girls who are out of education or do not have opportunities beyond high school. And this contributes to other challenges, including early marriage and its associated risks. Women also face other challenges which relate to perceptions of their role within society. So although women have sacrificed a great deal during the conflict, their contributions are often less recognised than men's. So despite these tremendous efforts, since the Syrian uprising, women's participation in public, social, and political life is very limited and remains a contentious issue, which is further exacerbated by the politics of the various groups that control different parts of Syria. So across Syria, we see different levels of political participation, and in the regime institutions, for example, women's participation has been deemed tokenistic and uninfluential. In the Northeast, women hold senior leadership roles across policy functions and at all levels of their institutions. However, female leaders have to balance new policies with the views of conservative locals. And in the Northwest, we see a lack of female leadership. In opposition-held areas, there is no pretense of formal legal equality or legal protections made. And so all of this, it greatly impacts the role of women in leading in other areas. So for example, health and in the response to COVID. The Women Leaders in Health and Conflict Initiative, which I will discuss a little bit later at the end, held a webinar to discuss the role of women's leadership, specifically in Syria, and its importance in supporting the health needs of conflict-affected populations within the country. And during this, we discussed various barriers, but also a number of opportunities. So we know that in Syria, women make up a large proportion of frontline healthcare staff. However, healthcare personnel here face considerable risks due to the conflict. So from March 2011 through to February 2020, Physicians for Human Rights documented the killing of 923 medical personnel and 595 attacks on medical facilities. And so it's very difficult, though, to obtain accurate data on how many female healthcare workers are impacted and what their specific needs are. But we do know that they are a very important group that we need to support. So while the role of women in the Syrian conflict has meant that they are becoming increasingly influential in the public sphere and in shaping Syria's future, within the health systems, we still see there is a lack of female representation in influential leadership roles. And this is hindered by the various fragmented health systems, the political situation, a lack of support from colleagues, and restrictive provincial rules to female leadership. And we see some examples of this through the exclusion of women in health leadership. So in the Northwest, a female candidate applied for a role on the Health Board of Directors. However, the candidate was unsuccessful on the basis of not fulfilling the criteria, which was a criterion that was created to purposely exclude women. In Northeast, we see there are attempts to empower women in society. However, their role in influential leadership roles still remains weak. Where gender issues intersect with other disadvantaged groups, for example, individuals restricted by poverty or living in rural areas with low opportunities to access education, then this further marginalises women who are aspiring leaders. And the COVID crisis too has reinforced all of these barriers and the gender gap. So the COVID task force in northern Syria, for example, is underrepresented by women, with just 1 woman and some 30 men. So while the conflict in Syria has been a major setback for progress and gender equity, there is scope for pursuing activities that support the advancement of female leadership in health in Syria. So we know that using the resilience, strength and voices of women in the Syrian crisis must be made visible. So increasing the visibility of women role models locally and at the global level through social media platforms and advocacy groups is vital. Also, open and honest discussions can aid in shifting mindsets by challenging gender norms and unconscious bias. So rather than using negative views, last week we mentioned, I'm probably going to say this wrong, but mistajili, which is an Arabic term for she is like a man. So instead we can reframe these ideas and our perceptions of who a leader is, and that, you know, it can be a woman in her own right. And also any discussions on meaningful leadership must include decision-making power. And also the role of diaspora, international communities, international institutions and advocacy groups is really vital in engaging with women who are aspiring leaders. I'll hand that over to you, Neha.
Thanks, Kristen. So Kristen just talked a lot about sort of examples from Syria, so I'm going to contextualize what she talked about by giving a more bird's eye view of leadership and decision-making in conflict settings. We know that despite global commitments to improving gender equality, the subject of women leaders in conflict and humanitarian health has remained on the periphery of the global health agenda. Why is this? We know that in highly securitized and politicized contexts, attitudes and assumptions toward leadership are predominantly male normed, as I mentioned earlier. Gender equality in leadership inhibits productivity and performance within health and humanitarian systems and has individual and national health and socioeconomic impacts. We have research from various sectors, including from leading humanitarian organizations, suggesting that global efforts to protect and assist people caught up in conflict and national disasters will be more effective if more women contributed via leadership roles. I believe, Kristen, you've led a paper on this as well. Women's representation and engagement in leadership roles would put women's issues at the front of the global agenda, challenge the traditional hierarchies of knowledge as well, and power by highlighting undervalued and unrecognized knowledge, and advocate for more inclusive, diverse, and representative decisions. Sarah Davies last week cited a webinar that, quote, just adding women might not be enough on its own, but this may support developing and embedding gender inclusive frameworks and mainstreaming gender institutions. However, in general, very little is known about how women are contributing to health and conflict-affected settings, whether as healthcare workers or decision makers or in other roles. This is a barely researched topic, either via quantitative or qualitative research. Even less is known about what women's leadership might mean in such contexts. And we know Kristen just gave us some brilliant example of some research from Syria, but there's very little out there. We know that health is an area delivered by women and led by men, and that women from low and middle income countries comprise just 5% of leadership positions in global health organizations. Just think about that for a second, 5% of leadership positions in global health organizations. But in conflict affected settings, we have no substantive data available on the number of women in health leadership positions. So it's a bit of a black box. Therefore, we need more evidence-based research to drive this change. Including policy change. So thinking about policy and key actors, the multilateral system plays a critical role in establishing women's rights and gender equality as a global norm. Mr. Niyi talked about that at the start of our webinar. And we're seeing this somewhat in the role of women's leadership in COVID responses. Research has also found that anything that undermines the multilateral system has a negative impact on women and on their position in society. So in 2019, the Global Preparedness Monitoring Board called for the involvement of more women in planning and decision-making as a vital part of sustainable outbreak preparedness efforts. Drawing lessons from previous disease outbreaks, such as the Ebola outbreak in West Africa from 2014 to 2016, as well as Zika, we know that women were less likely than men to have power in decision-making around the outbreak and their specific needs, which resulted in their health needs being largely unmet. Despite these lessons and recommendations, decision-making bodies established specifically for COVID-19 have not always reflected a gender balance. Analysis of recent emergencies have also clearly demonstrated that little has been done to actually ensure that women's voices are included in decision-making processes. And this has a serious impact in conflict settings too, as mentioned in the example that Kristen gave of Syria. So this is a call for diverse, inclusive leadership that is urgently required at local, national, and global levels to improve pandemic preparedness and responses in conflict settings and to mitigate their gendered impacts. Empirical research has shown that conflict and humanitarian crises create potential spaces to challenge these barriers. So women's rights groups, advocacy groups, and localized responses can facilitate shifts in power and resources and transform gender relations and empower women. For example, grassroots or community level leadership is an important way to challenge traditional leadership roles and to start to dismantle structural and cultural barriers. Creating strong networks is important, and enhanced collaboration between both researchers and practitioners will strengthen networks and increase evidence-based research that's urgently needed. Most critically, the voices of women in health and conflict must be made visible by first listening to them and documenting what they say, and then by amplifying them through social media platforms and advocacy groups. So to conclude, advancements in gender equality across the globe risk being derailed by the COVID-19 pandemic, and this will likely be further exacerbated in countries impacted by conflict, as evidence suggests. And Chris and I have been both saying women and girls living in conflict-affected countries are particularly vulnerable to both the direct but also indirect impacts of COVID. Despite overwhelmingly working on the front line as health workers, the diverse needs of women and subsequently their families and communities are often not met as they're not included in these decision-making processes. I would also add that it's critical to apply an intersectional lens when thinking about gender and leadership in all settings, but particularly in humanitarian settings where these vulnerabilities are amplified. I mean, this is because women don't form a homogenous group. So when they're excluded in decision-making and policy implementation, other groups are also disadvantaged. Therefore, advocating for more women as leaders and decision makers at all levels in conflict settings is crucial to adequately address the gendered complexities of pandemics to better support vulnerable populations. Over to you, Kristen.
Great. So I just wanted to mention, just at the end, I had mentioned earlier about the Women Leaders in Health and Conflict Initiative, which a lot of the work that Neha and I are currently doing comes through this. And it's a partnership here at King's and at the London School. So, and it's a collective effort responding to this growing grassroots demand from women based in conflict-affected regions around the world to improve the health of conflict-affected populations. So the initiative adopts a unique position within the broader global movements working towards gender equitable leadership, focusing on a domain that is under-researched and under-resourced given the complex political, security and research environment that it's positioned in. So although there are significant barriers, which we have highlighted, preventing women from taking up leadership roles, we have also mentioned that there is a wealth of opportunities. So we really want to highlight and support the work of women leaders and the groups that they represent in conflict and humanitarian settings through this platform. And so a core objective of this initiative is to develop a diverse network that effectively translates research into practice by working in close collaboration with academic partners, NGOs, humanitarian practitioners, policymakers, anybody really that wants to be involved. So, you know, if this does sound like something that you are interested in hearing more about or getting involved with, then please do reach out to us. I will put something in the chat box as well about that. So thank you so much for this opportunity to discuss all of this work. Thank you.
No, thank you very much, Nia and Christine, for that very engaging presentation. And sort of, it's really alarming to hear about some of the figures you recited about people who were affected in humanitarian settings, and also how women and some of the issues they're affected by are marginalized. Also very interesting was your comment about not just focusing on getting women leaders, but also thinking through about intersectionality and making sure that multiple vulnerabilities are taken into account. So I'm sure your presentation is going to spark a lot of interesting comments and questions. So we're looking forward to seeing some questions in the during the question and answer session. So thank you again for your presentation. Thank you. And now we're going to ask Deborah Delgado quickly to present on some of her work on mainstreaming gender and social inclusion in conservation and climate change responses. Thank you.
Hi, thank you very much for joining these voices here and organizing this panel. I'm learning a lot from these presentations. So I'm going to take you to another place in the continent, in the world, to another continent, another reality, but has a lot of that has a lot of parallels to be made with what you just presented. It's not a context of open conflict, but of slow violence, where indigenous peoples have been exposed to discrimination, and particularly on health issues and global health issues, like and environmental injustices for a very, very long time. And I've been working with indigenous organizations on climate responses, and it's from this standpoint of view that I started to work about COVID. And yeah, because before that, I worked with oil spills and climate change in Peru. So as these presentations show, the responses of COVID have been multi-level, and I will focus on the grassroots response linked to the subnational level. But of course, what I'm presenting has several layers and several levels. I'm focusing on the agency of grassroots organizations. And yeah, we still don't have enough information about how COVID has impacted indigenous peoples and the Amazon basin as a whole. The day before yesterday, a study conducted by Montreal University had some interesting insights on how COVID has affected Indigenous peoples communities in the Amazon basin, on Loreto and Ucayali, which is the first quantitative study that has already been published, but is still preliminary. And what I'm working on with a grant of the SSRC is the response of Indigenous organizations, and I'm focusing a lot of Indigenous women role in these organizations and how do they acted facing COVID. And what I'm going to present is some preliminary findings on that. And what I wanted to stress is that the context where they came from to act about COVID had to do with a long story of self-organization and then some support coming from climate policies that gave them some budgets to strengthen their organizations as Indigenous women. So yeah, so what I'm going to show you here, it's a grasp some starting points of an ongoing research that we will finish the fieldwork in November. What we are describing is how do women act and how COVID and its aftermath will affect Indigenous people's position and their organizations and their territory. And this is Santiago Manuin, who was a very important Indigenous leader. And he died from COVID after receiving bullets on his body during the Baguazo uprising here in Peru that resisted legal changes that were as ambitious as the ones that Bolsonaro is it's forcing into the Brazilian law, but were resisted in Peru and didn't pass through. So just to give you an idea on how COVID has impacted Indigenous people's leadership. He was a historical leader, and he has been one of the victims of this crisis. And the first image that you see here, it's a painting that was done during COVID to commemorate the resistance of Indigenous peoples to colonization during all these hundreds of years. So I'll focus in Peru, then I'll give you just a little brief context of the Pan-Amazonian reality now, and then some underlying conditions on what is lacking for a proper response to COVID and perspectives after the outbreak. So first, I wanted to give you some examples on how the lack of territorial coordination had consequences for the Amazon basin. So one of the main, the most affected areas has been Loreto, the one here, and they had a lot of victims, 2,541 registered victims. And now the number of people that is hospitalized is few. And so our first wave is over, but the toll has been pretty high. What Indigenous peoples did to resist this was to isolate themselves. But anyway, the answer of the state has been pretty detrimental. They have received therapeutics that were not adjusted, hydroxychloroquine, and has been given to Indigenous peoples, which is not at all recommended. And the subsidies that the state has given to Indigenous peoples and anyone that was under the poverty line made an incentive for people to leave their communities that were isolated and get COVID. So it's actually the state that drive the contagiousness of COVID. And also in Ucayali, the people that is more connected to urban areas had very high tasa, a very high toll of cases. And the region we're working on is the red one here. It's called Ucayali. And what we are focusing on is on all this networked response to very scattered and slow strategy from the state to focus their actions on indigenous peoples. One very interesting example is what indigenous peoples called Comando Matico. Matico, it's a plant that has very good therapeutic characteristics for low, like for mild cases. And they have organized places for to host people and isolate people that had mild cases and accompany them out of the crisis, respiratory crisis mainly, using these traditional knowledge and recipes out of this plant. So they have recovered these recipes around Matico and other plants and send them the recipes around by WhatsApp, surpassing frontiers from Colombia to Peru, from Peru to Brazil, and inside the subnational levels to share the recipes that may work better to treat the mild cases, isolate their communities and isolate the people that had some kind of crisis. But of course, the social distancing wasn't practiced as it was practiced in Occidental context. So that is one thing that we're focusing on. But the action was taken. At the same time, this is a video of a recipe being done, a Shipibo women sharing this recipe of different plants that proven to be effective. But they didn't stop to this recovery of traditional knowledge and innovation from it, no? Trial and not much error actually. And they also criticized the slow strategy of the state. And they had pointed to the lack of articulation and request budget for a proper plan to approach them. So their leadership and the women leadership was key on this. So this is Tabea Cacique. She works at the Pan-Amazonian level, but she is from Ucayali, and she was very, very key talking about this, pushing forward a proper plan for indigenous peoples coming from the subnational level. And at the national level and international level, ONAMIAP, which is the national organization, criticized the lack of health services, that is an underlying condition, and they started a legal action that started in June 17th, and they demand the state, and then it was taken to the CIDH, which is the Human Rights Commission at the Inter-American level. So you see there's different kind of actions and leadership that indigenous women has taken to react to the pandemic crisis. And in the context of the Pan-Amazonian reality, you see that the frontiers have been a focus of contagion. I mean, the borders between the countries. And you see the points here of where we found in May the cases of COVID concentrated. So again, just to give you a context, Amazonas was the most affected area from where the cases went to Peru and to Colombia. So it's important to take into account that borders in the Amazon basin are very fluid. People travel around, and as well as their knowledge. So it's important to take into account that the action that Bolsonaro takes in Brazil has consequences for Peru and what he has been changing in the health system. and in the law for the protection of indigenous peoples' territories have a long-lasting consequence for Peru and Colombia because of the size of the country and how they content their health crisis was a positive action for us, and now this is not working anymore. Colombia has the same dynamic, is the frontiers that were more affected. So Leticia was a very focus of the pandemic. So what changes might be coming and what changes should be coming? Well, health systems in the Amazon are a key priority. We know that other pandemics might actually start from the Amazon basin. So we see a lack of capacity there, and the situation is exacerbated by the lack of budget for transportation of medicines and protective equipment. There's also no capacity to attend to moderate and severe cases with a higher risk of death. So that's why indigenous women acted. And there's a deficit of health personnel because they contracted COVID-19 and they couldn't go to the community. So it was a perfect storm produced by the historical lack of health infrastructure, and then how the virus worked. So indigenous women particularly responded to these conditions. And what we see in the future is that development projects and reactivation may be imposed into these territories again. So to close up, what I think is like a fast balance is that the countries in the region have acted without coordination. And even at the subnational level, the coordination was pretty poor. We observed timid attempts at the subnational level that may be interesting. So Ucayali for us is a case because they did answer and hear indigenous peoples. So we think we might learn from this, no? And these kind of cases, we see them also in other areas, such as education, for example. When a grassroots organization has a built capacity, a subnational level government may support that capacity. So maybe that it's a lesson learned that we can use for other global health challenges. So this space where the grassroots organization and the subnational level meet may be a way forward. And this is my main message. And there's where we can promote women leadership, because it's there and it's just a question of lifting it up. Yeah, so we have a region that is still not resilient. If we have actually not a pandemic that comes into the region, but a pandemic that starts in the Amazon, which is pretty probable, and we know that that can come from zoonotic diseases, we have to think about how the resilience of the region. And what we are starting to see is that a path forward is these social ties of solidarity that we see on the ground from the grassroots level up, these networks that are there, that have been there for at least 30 years and historically from way before, with a gender focus. Because if we use the gender lens, we start to see the leaderships that I'm trying to present you here, and they are the most effective ones. And another thing that we have to take into account is to distribute better the resources and optimize the built, but also the natural infrastructure, at least in the Amazon basin. And I would argue that in many other cases, natural infrastructure, so the rivers and many other ways, the paths and have to be optimized so we can use them to be more resilient and not destroy them and be less resilient in the forthcoming crisis. So that's my presentation. This is an ongoing work. We are still collecting data from Ucayali, very interesting interviews there and conversations and material, cultural material, all the propaganda that they use to spread the information and everything. So yeah, so this is what we're doing, and I hope it's useful for you. Thank you.
Thank you very much, Deborah. That was really an interesting presentation. I have to say I was impressed sort of listening to you talk about the way Indigenous women were able to come together and share information using very innovative ways, and also advocate for their rights. I also like some of the recommendations you made about working with these groups also at the subnational level as well. And I think there are lots of lessons to be learned. We have some questions for you, but we're going to wait for the next presentation, and then we're going to open the question and answer session. So please, everyone, keep leaving your questions. We'll be available to respond to them shortly. Thank you so much, Deborah, for your presentation. The next presenter we have is Dr. Niyi Ojuolape, who is a consultant pediatrician and is working with AISE Permanente on adolescent and sexual and reproductive health. And she's also a principal investigator in a few research projects focused on adolescent health. So I'll let Annie speak now. Thank you.
Thank you, Emmy. Can you hear me okay and see my screen?
Yes, we can.
Well, good morning or afternoon, everyone, depending on where you are. Thank you to Emilomo and to AISE for inviting me to participate in this webinar with such a distinguished panel. Wow, it's been so enlightening to hear from all of you, and I have so much gratitude for the important work that you all are doing. So I'd like to spend my time highlighting some unique challenges that adolescents are facing during the COVID-19 pandemic in my practice area in and around Seattle, Washington in the US. And as Emilomo mentioned, I'm a pediatrician practicing at AISE Permanente. AISE Permanente is an integrated care and health insurance system in the US that serves about 11 million individuals across the country. We have 9 regional hubs, and I'm part of the AISE Permanente Washington system in the Northwest region of the United States. And within our region, we have what's called an adolescent center. And this is a multi-specialty group of physicians like myself, psychologists, therapists, and a consulting psychiatrist, a child psychiatrist, who care for adolescents in a team-based model. And these teens typically have intersecting medical and mental health needs. So some of the most common reasons I see teens are for care of eating disorders. I do gender-affirming medical care for transgender and gender-diverse young people. I provide quite a bit of sexual and reproductive health services like STI testing and treatment, contraceptive care in a comprehensive way, and care of menstrual concerns. And then I also see young people who present with complex mental health disorders with strong somatic components like chronic pain that's debilitating, or chronic physical symptoms tied to anxiety or depression disorders. So I also wear a few other hats at AISE, including as an adjunct investigator in our research institute, where I'm currently consulting on a project to implement universal depression and substance use screening among teens in the primary care setting. And I've worked on a range of adolescent SRH projects, both here and in lower and middle income countries throughout my career. And I also have the privilege of serving as an advisor to our clinician recruiting and hiring team, so working specifically on promoting equity, inclusion, and diversity in our hiring efforts. So it was really wonderful to hear about the power of women in leadership from some of the other presenters. So I will disclose up front that I am by no means an expert on COVID-19, and my role in this pandemic has largely been in providing care and support to teens and families without COVID who have health concerns that have arisen as the result of many protective structural factors that keep young people well, like safe educational spaces and extracurricular activities like athletics and part-time jobs, as those opportunities have been shut down or fallen away. And I think you are all aware that our country has struggled to contain the spread of COVID-19. And while children largely have less severe disease and much lower mortality rates than adults, we are now seeing more confirmed cases in children than ever before. Our most recent pediatric data that was released the last week in October noted 61,000 cases among children ages 0 to 19, with over 850,000 children having tested positive since the beginning of our outbreak. And it's important to note that adolescents aged 12 to 17 years who are tested for COVID are twice as likely to be positive as those children 5 to 11 years. And overall, children represent over 11% of all confirmed cases in the US, with substantial differences by state, which likely reflects differential containment and testing strategies by state, as we have lacked, unfortunately, a coordinated federal response to our nation's pandemic. So these graphics demonstrate the differential numbers of COVID by state and where we're seeing the most dramatic increases in case counts locally. Washington State, which is in the upper left-hand corner, was the site of our first cases of COVID in the nation, but fortunately, we are not now seeing as dramatic of a surge as some other communities are facing this season. And so when we think specifically about adolescents and their health, it's important to remember that adolescents are evolving. They're evolving physically and cognitively and socially from the onset of puberty into adulthood. And this figure, which was initially published by George Patton and his team at the Lancet Commission on Adolescence, highlights how interrelated the social determinants of health, like economic development, status of gender roles in the community, et cetera, interplay with risk and protective factors at various interpersonal levels, and how these influence health-related behaviors and outcomes along this developmental continuum. And WHO defines an adolescent as someone aged 10 to 19, which largely captures individuals from the beginning to end of physical development and puberty. So young people are defined as age 15 to 24, and that older age range captures the ongoing social and cognitive development that is happening after someone is the legal majority age of 18 in many settings, that there's still a lot of cognitive
Hi, Annie.
Is it just from me? I can't hear.
Yeah, I think there's something up with her connection. So I'm just going to send her a message, okay. And if she can connect, that would be great. But if not, we'll just continue with the session. Oh, hi everyone. I think we've lost Dr. Hoops. I am just going to send her a message to check with her and wait for her to join. Meanwhile, please keep sending your questions, and then we'll start the panel session shortly. Great, fantastic, you're back.
Sorry about that. Oh, my deepest apologies. I got kicked off of my network, so I'm getting back into my slides.
No problem, thank you.
All right, can you see my slides and hear me okay now?
Yes, we can.
Okay, all right. So I was talking about Urie Bronfenbrenner's social ecological framework, which highlights all of the layered spheres of influence on an adolescent's health and well-being. And we have to consider how the characteristics and behaviors of the individual adolescent, and then their immediate and extended family, friends, and intimate partners, and then healthcare providers and health services, exposure to public health interventions. All of these things shape adolescent health and well-being. And then we further have to zoom out and think about characteristics and behaviors of their schools, workplaces, and neighborhoods. I would add law enforcement in our nation. I would add health and social policies, societal and cultural norms, and structural factors like systemic racism. So this socio-ecological framework really helps us think about how all these levels of influence are changing in the context of COVID-19, and that's kind of what I want to highlight in some case examples. I also want to highlight the presence of youth voice in this pandemic by sharing 3 resources that I've linked at the bottom for you all to take in on your own time. One being a local Seattle newspaper article in which 3 teens in my community share about their experiences during the pandemic and the concomitant Black Lives Matter racial justice movement that we're experiencing that I think really kind of gets intimately at what it feels like to be a teen during this time. And another on the right-hand side where it says Quarantine Vibes, this is a digital zine or magazine published by the CI3 Youth Advisory Board. And the zine is called This Ain't It, which is a graphical representation of teen experiences during quarantine. If you don't know about CI3, they are this incredible youth-engaged, human-centered design workshop that specifically is creating sexual and reproductive health solutions for young people. And I would encourage you to check out their website below. It's at ci3.uchicago.edu. And finally, a video featuring the efforts of Youthcom, which is a youth communications nonprofit, is an intimate and authentic representation of how young people are developing their identities as advocates during this time. And while this time has been challenging for many in our community, the strengths, creativity, and resilience of young people cannot be understated. So as a healthcare provider who serves teens, our shift has really been traditionally, has been shifted from a traditional focus on face-to-face, one-on-one visits with young people and their families to a virtual first model in which every patient's needs are attempted to be addressed initially by a virtual contact via phone, video visit, secure messaging through an online patient portal. We have a chat service for medical advice, and then augmented by digital resources in the community. And so face-to-face care is really only carried out if necessary and not able to be met in a virtual capacity. And visits are modified to be as brief as possible to protect the safety of patients and providers. And so as many of you know, virtual healthcare has been work that's been in the pipeline for years, and it really has been implemented in small ways or in pilot ways, but the pandemic has really forced it to become the norm and the forefront of how we provide care. And we as healthcare providers are really learning how to shift our typical assessment skills to a virtual format. Some of the data that we would use in a setting like what the patient wears to the visit, do they have a coat to keep them cold or keep them warm from the weather, or do you smell substances on their breath that make you think about certain health concerns? Some of those sensory experiences we don't have access to anymore. So we're learning how to assess in a new environment. And adolescents have unique vulnerabilities in the context of this pandemic and of social distancing. And I'll share some case examples that highlight this. But we know that they have, as I mentioned, evolving developmental capacity and evolving skills to engage in healthy sexual and reproductive health behaviors and to navigate their SRH healthcare needs. We also are learning that they have limited access to privacy to participate in virtual care encounters. They might not have their own room in a household or a reliable device with accessible data for a phone or video visit. Adolescents are experiencing reduced access to lower barrier friendly SRHs in our communities, like school-based health centers. So in our area, typically every middle and high school, public middle and high school has a full spectrum health clinic located within the school building, where among other things, teens can get confidential and free sexual health care and contraception services. And all of those, have modified their access because the public schools are closed. They're still providing vaccine visits, but it's not kind of as ready access as it historically has been. And then we also know that comprehensive sexuality education that traditionally occurs in schools may be limited or modified during distance learning during a key time when knowledge acquisition during this difficult stage is needed. And as I mentioned, teens are less exposed to protective factors such as educational advancement and employment opportunities, their religious communities and extracurriculars like performance, like theater, like sports. So all those things are shaping how healthy adolescents are at this time. So I'm going to shift to discussing a few cases, and then Emmy, if I'm running out of time, just give me a signal, please, and when we can wrap up. So the first case I wanted to share, these are all real cases that I've cared for in the past several months, is a young woman who we'll call Kay. And Kay is 17, and she several months ago contacted her primary care doctor by phone for concerns about pregnancy. She had been prescribed birth control pills several months prior, but had not gotten them refilled when COVID began, didn't have access to the pharmacy. So her provider advised a home pregnancy test, which she took and was negative, and she was subsequently referred to me for contraception counseling. And during this time, as I mentioned, face-to-face healthcare visits are substantially limited to minimize the spread of COVID-19, and only patient complaints deemed essential were able to be scheduled. So I had an initial phone call with her to confirm that pregnancy had been ruled out. She had had 2 negative pregnancy tests separated by 2 weeks without any sexual activity in the meantime. She shared that she had previously been taking the birth control pills, but even when she had access to them, had struggled with adherence. She said, I'm just not an everyday medicine person. She was interested in changing her birth control method, but had concerns about the procedures required for long-acting methods and whether it would impact her fertility as an adult. These are very common concerns for teens. She was currently in a relationship ongoing with a boyfriend, and while they had been practicing social distancing from many of their peers, they had a contract that they could spend more and more time together as long as they weren't exposing to other people. So she had previously been active in school athletics prior to COVID, but was finding herself increasingly bored without any extracurriculars or limited school requirements. So in talking to her on the phone, I offered to convert the visit to video in order to talk about different contraceptive options using some visual aids. And the video platform allowed her to become more comfortable with me as a new provider and build trust. And I discussed how long-acting methods are safe, very effective, can last for years. These are intrauterine devices and contraceptive implants, but they can also be removed whenever a patient wants and do not affect fertility in the long term. And I made sure to reinforce the importance of personal choice in a contraceptive method and answer questions patiently. And this young person decided that she would like to try getting an IUD. So in order to minimize time spent in clinic, we reviewed her consent form for that procedure in depth by video, and she was sent a digital information packet about IUDs to review further. And we scheduled her for an IUD placement in clinic in the next face-to-face spot available, ensuring that she was symptom-free at that time. So she arrived at the visit, and we followed clinical protocols of her attending the visit alone if possible, hand washing upon arrival, and wearing a mask throughout the entirety of her visit. Her medical assistant actually noted that she was overdue for her HPV vaccine. So she offered her a preventive immunization at the time of the visit. And then we subsequently placed her IUD without any complications. She got STI testing at the time of her IUD placement, all of which was negative, and she was given condoms and counseled about safer sex practices. So here we were needing to balance the risks of COVID infection and the risks of an unintended pregnancy and kind of navigating what we could do to serve the patient in that moment. And so reflecting on kind of what allowed that to be a successful care journey for that young person, we had an institutional policy that clearly defined contraceptive visits as essential if the patient was at risk for unintended pregnancy. And then schedule her for a face-to-face visit. And in the meantime, a functional video platform, unlike the one I had this morning, allowed for trust and rapport building during an initial video encounter that was more time intensive to minimize the time spent face-to-face in an office encounter. And then we were able to opportunistically immunize the patient when she was in clinic, which would have otherwise been further delayed until her next preventive care visit. And then Another thing that was supportive is the patient's parent had previously spoken to her about contraception and provided transportation to and from the visit to minimize contacts outside of the household. So she didn't have to take a bus or other means of public transit to get to our clinic. A resource that supported this work was recently published in JAMA Pediatrics earlier this year, and it outlines why contraception for teens during a pandemic is deemed essential and provides this very user-friendly flow sheet to providing virtual contraception options when safe and appropriate and when in-person care is needed. So I'd refer you to that for more information. Okay, my next case highlights the challenges of LGBTQ youth during COVID. And this is a patient who I'll call M, and he is a 16-year-old male who lives with an adoptive family. His birth mother struggled with substance use disorder and sought adoption for M shortly after he was born. And M himself began experiencing depression symptoms about 4 years prior when he was 12. He established care with a mental health provider, initially receiving counseling and eventually medications that were prescribed by me as his adolescent health provider for worsening depression and anxiety. And unfortunately, M actually attempted suicide by Tylenol or acetaminophen ingestion 2 years ago, resulting in a brief hospitalization for stabilization. And after his suicide attempt, he confided to me as his medical provider that he was gay. And he shared that his adoptive family's faith did not acknowledge LGBTQ identities, and that he was very fearful if they learned that he was gay, that his family would be ostracized by their church community, and that he may even need to leave the home. So I expressed support for his sexual orientation and agreed to keep that information confidential unless he wanted assistance in disclosing it with his parents. So a year ago, right before the kind of onset of the pandemic, maybe the fall of last year, M was doing better, and he transitioned from a homeschooling program that he had chosen years prior on account of some social anxiety to a public high school. And this unique high school was actually designed to support people with learning and mental health challenges. He was in smaller classes, shorter school days, and had a school environment that was very inclusive and welcoming to LGBTQ youth. He began growing more confident in his identity and made some new friends, and he even met his first boyfriend. So things were going well for M, and then COVID-19 happened and schools were closed, and M had to transition to distance learning. He began struggling with worsened anhedonia, or low, decreased interest in activities that he used to enjoy, low mood, inattention, poor sleep, and appetite. He was spending a lot of time playing video games and had difficulty keeping up with his schoolwork. And it was really difficult for him to maintain communication with his boyfriend without his parents becoming suspicious. So at one of our phone visits, I asked how his boyfriend was doing and whether they were keeping in touch. And he responded, "I don't know what you're talking about," and was very terse. And it was very clear that that topic was not something that he felt comfortable talking about. And later that evening, I received a message from him in our online patient portal stating, "Please don't talk about my boyfriend during our visits. My parents are always listening." And so he stopped actually all phone counseling visits because he didn't feel comfortable sharing things by phone, and his mental health has been deteriorating. So as this exemplifies, privacy is such a critical aspect of adolescent healthcare delivery, and virtual care really reduces barriers to that access for many, and also presents new challenges in terms of how we can assure privacy and confidentiality, how to respond to reports of acute suicidality, abuse, or neglect by a teen who's not present with you in clinic. So in this scenario, we definitely tried to find avenues to prioritize face-to-face healthcare opportunities for a young person who lacks privacy for virtual visits. We encourage our teens to use headphones or earbuds and to use a chat feature in our video portal to allow for nonverbal communication that may feel more private or safe. And then we've also been doing a lot with our LGBTQ patients to ensure that they have access to digital spaces that affirm their identities. In our region, community-based a virtual Pride celebration, both on Minecraft and Discord servers where youth are. They're having Zoom support groups and maintaining crisis phone and text lines for young people in need. And then we're also really trying to take this opportunity to coach parents about how to support their teens during quarantine, offering private space, offering opportunities for them to get out of the house and individuate from families in safe and distance ways. And that has been a journey while also kind of protecting teen confidentiality about some of their unique needs. And I just want to highlight 2 organizations nationally that are offering digital support services to LGBTQ or queer youth. One is the Trevor Project, which has both chat, phone, and text-based crisis line resources. And the other on the right is the Family Acceptance Project, which is really geared toward parents and caregivers of LGBTQ youth, particularly those who are struggling with kind of reconciling faith identities that are not accepting of LGBTQ identities, or cultural differences that kind of really make some of those parenting experiences more challenging. I don't think I'll have time to go through my last case, but maybe it'll come up in examples. But this one, again, reflects a shortcoming of virtual care around a teen who experiences an unintended pregnancy and is needing to get support for pregnancy options. And one support resource that I want to highlight as we're wrapping up is a new service that was released by a national organization called Power to Decide, which is committed to preventing and supporting teens experiencing unplanned pregnancy. And they have a service called abortionfinder.org that is beautifully designed, evidence-based, and allows for a young person or someone of any age who's seeking abortion services to enter their location, their last menstrual period, and their age, and get real-time information about what clinics can offer them comprehensive reproductive health services. And so I just wanted to refer to that. And then some additional resources that our Society for Adolescent Health and Medicine have culled, both for parents and teens who need support during the pandemic, and clinicians and researchers. Thank you all for your time, and I will look forward to discussing more during the panel discussion. I've included my email here if individual questions come up.
Thank you very much, Annie. That was Dr. Andrea. that was a wonderful presentation, and I really like the illustrative case studies. I think they clearly show the way the COVID-19 pandemic has influenced different kinds of adolescents and with different kinds of problems. And I think that brought a very human picture to the story. And also for sharing some of the interactive tools you've been using to provide clinic visits. So at this point, I'm going to invite all the panelists to come to put on their videos, and we're going to we're going to go through some of the questions that have been posed by the attendees. I see some of them have already been answered, and I'm going to just go through them and pose the questions to all of you. So I'm going to start from, so some of these questions are not particular for one of you. Some of them I think it will be interesting to get perspectives from all the presenters and your expertise in the different contexts. One of the questions was regarding, and this has already been answered, but it brought up the fact about preventing transmission. So Mr. Ojuolape discussed some of the responses he had in Ghana, including, and I was really impressed by your door-to-door visits and your door-to-door provision of services and information, especially during the pandemic. And this person actually says, question is, what kind of preventive measures did you provide, and how are you able to provide that sort of community-based outreach at this level during the pandemic, and also prevent transmissions?
Yes, we must appreciate the fact that, thank you very much for that, Doctor. And I also want to thank the person who asked our questions, because it enables us to elaborate on how we went about this. Now, the issue is that we were in an emergency. And what we do in the UN is to, as much as possible, stay in there until it is totally impossible for us to continue to stay. It's only when it affects people, it affects the lives of our people. We just do what we call program criticality tests, and we carry out an exercise to determine if we should continue to stay in there. But then it's during the period of emergencies, during the period of crisis, that is when work actually comes out to the fore. And therefore, with the advent of the COVID pandemic and with the lockdown, we saw an opportunity, even though it's in the midst of danger. So what we did when we were going to do the door-to-door program was to check each and every. I mean, we have a cohort of young people in our office in a what we call in a youth fellowship program. We call it the ULA fellowship. It's a leadership fellowship. So we have them. There are 21 of them. Apart from that, we have some youth networks that we work with whom we implement our programs. Under normal circumstances, you're not going to see health workers or other people who you would normally have used to implement this, because it was in an emergency and the president has said everybody should lock down, you know. So what we did was to first do a snap training to give them, because we have been training them before now. And we've been training them because we have what we call the emergency preparedness action. So we've been planning this in anticipation of this situation, for them to understand that, okay, if this happens, we have scenario 1, 2, 3. If this happens, this is what we do. If we're in scenario 2, this is what we have. So they have that training. So we did a quick refresher training. Then we brought in some other young people who have also been attending our trainings concerning this. We brought them together. So in practical terms, because it was COVID period, we give them personal protective equipment for them to do the door-to-door. There were actually 2 types of the door-to-door activities that they were carrying. There were some of them, there were certain points at which the way they dress, you think they are Eskimos. And it is because they were putting on the personal protective equipment. And that in itself has the added advantage of drawing attention to them, that who are these, what are they about? And so they draw the attention of people when they come in, and then they have that as an entry point to get in to speak with them. So we give them the personal protective equipment, all the sanitizers and what have you. And they were also carrying sanitizers and the little, face mask and what have you, as part of what the reach out that they were doing. So we're also reaching out to sanitize and all of that. So during that period, we gave them training, we gave them information and education about a refreshing information and education about the pandemic, about the virus and its spread and all of that. And then we also enjoined them to be very careful. So they have the personal protective equipment, which is actually most important for any health worker. So we treated them like health workers, and then they went out to do that. And we actually did in targeted communities, looking at particular areas and to say the entire households in this area we're going to cover it. And then they also went there in their numbers. But the real issue is being careful. If we can operate in places where bullets are falling every day, you can imagine that we'll also have taken enough care to make sure that they don't fall victim of the virus during that time. That's what we did.
Thank you very much, Mr. Ojuolape. And those are very interesting ways and innovative ways of ensuring people get health care while protecting them from COVID-19 transmission. And right now, I'm going to just jump to Dr. Hoops because of the parallels and the differences in your settings. Because, for example, I understand that in the US now, there is more provision of virtual care. And you sort of highlighted some of the challenges that brings up, especially for youths that consider themselves quite marginalized, LGBTQI youths who would have benefited from more one-to-one care. So can you share some of, you discussed some of the challenges, but I was interested in knowing how did you address some of these issues, some of the mitigating strategies that could be used in these times when you have more virtual consultation?
Yeah, I think it's an ongoing challenge, and we're sharing experiences across our professional organizations. I participate in a pediatric transgender care professional organization and a Society for Adolescent Health and Medicine, and kind of what are the best practices. And what's emerging is kind of really affirming right away that teens have very unique needs, and kind of individualizing care whenever possible, such that if someone, many teens are doing great with virtual care. They feel comfortable being in their own setting. They can have their pet with them while they're having a visit. They're on their terms in a way, and they're very facile with digital technology in a way that I think makes it a very comfortable space for them. But as I mentioned, particularly youth who have experienced family rejection or kind of have confidentiality issues that threaten their health and safety, that they require creative outreach strategies. And to the point of one of the question attendees, the issue of social deprivation, that a key developmental task during adolescence is identity formation. So figuring out who you know yourself to be and how you are different from your family of origin. And in order to form that identity and iterate on it, you have to be exposed to peers and individuals who are different from you, and have trial and error of kind of what some interactions and settings and peer groups feel like. And so for all of a sudden, those kind of opportunities for identity exploration have fallen away. It's really intensified kind of, the not only the isolation, but just kind of, it's halted that developmental process in a way. And so, we've really been coaching parents on how to make space for their young people similar to how they would have it. Like when you are at school, that is time that your parents aren't going to kind of intrude on your energy and your social setting, right? And so families need to really work on setting up a contract of these are the hours of the day where we're going to spend time as a family. And these are the hours of the day, even if you're here in our household, that you have time that feels private and autonomous. And that teens need to figure out how to negotiate those needs. And I've really been impressed with the teens in my community who have sought essential work in the workplace, are working in food service or doing volunteer work, so that in safe and socially distanced ways, they're able to get out of their household and continue that identity formation process.
Thank you very much.
At the same time, we're struggling with a mental health crisis, and unfortunately, hospitalizations for suicidality and deaths by suicide have been increasing during this time. So we're realizing that we're not quite doing enough for all of the teens in our community.
No, definitely. And I imagine mental health is an issue that comes up in many different settings because of some of the challenges of the pandemic and social distancing. And I'm just going to also, in response to that, and also linking with Dr. Neha's and Christine's presentation and also Deborah's presentation, you really highlighted the importance of putting women in leadership positions in responses in humanitarian settings, but also in conservation and climate change, and how that brings up some of these issues that are neglected in interventions. And I would like to speak to that because one of the questions from one of the attendees is that there's always an assumption that if, for example, you put marginalized populations, in this case women, in leadership positions, that everybody will be represented. And the question was, how do we know that we do not reproduce patriarchy, because the women are also a byproduct of the patriarchy and there's no proof of that. And also linking with some of the things Annie and Mr. Ojuolape presented about community-based responses. These are wonderful examples, but they're not common. So how do we work with what we already have to ensure we get from where we are now to somewhere where responses are more inclusive, take into consideration vulnerabilities, marginal groups?
Shall I start with that, Neha? Yeah. So yeah, just looking at that question that had been asked, it's a great question, and it's a really important comment and question to make. And I understand that this, when you read the reports on the news and the media at the moment, in the response to COVID, there's this focus overwhelmingly on women, and that women are making better leaders essentially. But we know that there's, this is quite an outdated view that men and women have different leadership styles. However, as the person had mentioned as well, we don't have enough research on women's effectiveness as leaders, and especially in humanitarian settings, which are so complex, as we've been discussing today. So I think it's about looking at leadership from a different perspective, so a more holistic and inclusive approach. So not necessarily that male normed approach, which we so often see, particularly in humanitarian settings. So through this gender lens, and a gender lens doesn't mean looking at it from just focusing purely on women. It's men, women, and all of the intersecting identities as well. So looking at the involvement of women and women's contribution in leadership is really important, but it's almost like a starting point. Which can sort of move us towards maybe developing and embedding gender inclusive frameworks, mainstreaming gender, those sorts of things. And again, as we've been discussing, a lot of our research focuses on humanitarian settings and armed conflict that are incredibly male normed. So, just discussing women is very much an initial step. So, yeah, I hope that clarified it a little bit.
Thanks, Kristen. I think just to add, Savita, thank you for your really important question. I think just to add, I think there's a lot of agreement and a lot of calls, a lot of advocacy to engage men on this issue, which I think everyone on this webinar will agree with. But it does not mean that that they seek to challenge harmful gender norms or unequal power structures by just engaging men, quote unquote. So I think we need to unpack that quite a lot and to test it and to figure out how to best do it. Because without a gender transformative approach, male engagement interventions may risk undermining women's autonomy and reinforce existing gender inequalities. So for example, any interventions to engage men as allies to improve women's access to healthcare appear to be positive, but such programs can also or should include components to foster shared decision-making. Otherwise, they may reinforce cultural norms that women need to seek permission from men before making decisions or accessing care. I also agree with your point that we can't automatically assume that women in leadership roles will be more sensitive towards vulnerable groups. And this is why I touched, I think, too briefly on the issue of intersectionality. So gender intersects with colonial and other power hierarchies and identities, including migrant refugee status, race, ethnicity, age, economic status, sexual orientation, and gender identity to heighten inequalities, in particular in conflict settings, but really globally. So it's essential that when thinking about how and whom to work with to address leadership issues in humanitarian settings, we purposefully need to reflect on and educate ourselves on conscious and unconscious biases, unequal power dynamics, intersectional gender power hierarchies, white privilege where relevant, and it's often very relevant in the humanitarian system, and notions of expertise, and then how these influence who has a seat at the table to make or influence decisions. I hope that's helpful.
Yeah, I would like to complement to what Neha just said on how to educate ourselves on how to approach these contexts. We have been reflecting a lot on decolonizing our methodologies, and this has been a very fruitful effort of reflection. And one of the things that we acknowledge the most is how Indigenous women have been self-organizing. And for example, the examples I was giving you on AMIAP was a reaction of Indigenous leadership, actually, of women and men alike. They had to go out of this structure to make their own structure to align their voices so they can go back to the mainstream Indigenous peoples organization with another standpoint of power. Their view was always different. And learning about that and following their processes and being an ally, a long-lasting ally. I mean, not all the time we have a project ongoing, but we can have a dialogue all the time. That has been very effective to educate our regard. And this is how we're trying to work. Like we can work on a particular project or agenda, but our compromise is way longer. And this is a challenge if we have to work in different settings a lot. But I think it's worth it because as a collective, we also learn to have a longer, you know, a project is a project, it's true, but we have a career, no? The same way as they have a long struggle, we can have a long compromise, and our project can be done, but our way of working not, no? It can stay. So this is the way we're trying to work now, and that has a lot of advantages because we see on the other side that this is appreciated and knowledge also flows. So we work together, we're starting to write together, and it's very, very productive.
No, thank you very much. And I must say, like, listening to some of your responses, it shows that there's a clear linkage with thinking through how to be innovative and how to also think of the benefits of having more inclusive and mainstreamed responses to some of these issues, whether it be in the US or in conflict and humanitarian settings, or in Peru or in Ghana. And also talking about gender mainstreaming is the first step, but it allows you to start thinking about more marginalized groups, and it can create opportunities for better engagement. And just to, there's another question that hasn't been answered, and I'm going to bring up, is the question around self-care. And this was specific to, I think, if I'm correct, it said DMPASC. I don't know whether that is referring to, I think maybe Mr. Ojuolape will know that better. I don't know whether that's Depo-Provera or contraceptive options, but this is a question I think is quite relevant for not just Mr. Ojuolape, but also for Dr. Hoops and Christine and Neha. In your experience, have you found people identifying more innovative ways of accessing care despite the COVID pandemic? So they use self-care, but I think it also applies to, for example, coping strategies in general, and other and access to contraceptives, or different ways of addressing their SRH or mental health or access to healthcare.
Is that a question for me?
I think it was for you, but I think it's
part
also,
of it.
Yes, yeah, I think it's also applicable. Yeah.
Okay. So actually, what we do with clients for whom we work on with self-injects, what we do is to give them enough supplies for a year. So when COVID hit, they had their supplies, and with their so we give them, depending on how long each inject is supposed to be for, we give them a year's supply. So the disruption of family planning services really did not affect them immediately. And besides, the family planning, the lockdown in Ghana was just for 3 weeks. So within the first 2 weeks, we're already working on what would be the alternatives, and we're trying to find a way to ensure that the family planning spaces are open. We're also working with our partners, especially Maristopes, to ensure that we have something in place. And by the time we got our acts together, it was just 1 week or 2 more weeks to go. So we're able to meet all the needs that arose. But the only ones that might have been in peril as at that time during that period was probably those who are with their partners, and the partners must not know what they're doing, so that they can't really access services confidentially, because those who do self-inject, they will have to do it themselves. They need the space to be able to do it. And so if they are maybe in a constricted space with their partners, it might be a bit difficult for them to apply. But we didn't really get any particular case that was earth-shaking. So generally for us in Ghana, we're able to look at that, because the bottom line is that they had enough supplies for 1 year. And in a short while, we were able to come back to normal, and then they could access family planning spaces. Yeah.
No, thank you. And it's very interesting to learn of your innovative approach to addressing this. I know Dr. Delgado has to leave soon, so I'm just going to give her the opportunity to answer one of the questions before she leaves. Dr. Delgado? You still there? Okay, I think she might have left. Dr. Delgado? Yes. Oh, there's one question. I know you have to leave. Thank you so much for staying with us.
Sorry, yes, I have to leave because I have something at the university that is pretty urgent.
Yeah, I was thinking just before you leave, there's a question regarding, and thank you for answering some of the questions already, but there's one about what hope do we have for have at all for eventual green recovery from COVID-19,
yeah,
and of that recovery being gender nuanced. And I thought that was really a key question, and I think it's good for our attendees to hear your response.
Yeah, at least in the case of Peru, Colombia, and less in Brazil, there's a lot of ongoing projects on green recovery. On halting deforestation that have been supported by the state. And that's why we are giving so much importance to subnational level, because the national level has some political will, but the subnational level that is closer to the frontiers of extraction resist that situation, because their economy is made to profit from short-term gains of deforestation. So this is a key battleground for green recovery, because it can make it more sincere. I mean, we all need now to reorganize our earnings. So this can be an opportunity to push forward some initiatives that are green driven. So for example, there's in the protected areas, initiatives for Chiringa, chocolate production, I mean, from cocoa to chocolate, in a very high level, let's say, very good quality produce. And these kind of green economy networks are very good for the environment, and it might be good for the economy, but we have to change some power relationships there. And there we see again gender issues. Again, you know, the ones that work more but don't get the credits usually are women in these structures, and we have already evidence on that. So, so this COVID-19 might be a disruption of local relationships that have been very bad for the environment that might change, because we have more information and better networks. But this is something to be seen. Like, we have better connection, Wi-Fi connection, telephone connection. All these things are good for what we're looking for. But at the same time, you know, patriarchy is also very strong. So we will see what happens. But there's room for being positive and, you know, having some hope for this. Definitely so. Yeah.
Thank you very much, Dr. Delgado. That was very useful information, and I think also very hopeful. That despite the existing challenges that regarding mainstreaming gender or more inclusive responses, that we can start from like some of the examples that you've provided, we can start with grassroots movements, and we can think of ways, innovative ways to work with these communities to bring about change. And hopefully, though COVID-19 has brought a lot of challenges, it has also brought new ways and opportunities and allowed us to think outside the current structure or context we were working with. Thank you so much, Dr. Delgado, for your time. I know we've run out of time, and I want to thank all the panelists and attendees because it's a Friday evening for some of us. So I really appreciate everyone sticking through. And there are a few more specific questions, but I'm going to probably ask, I will first do sort of a round table and ask all the panelists to leave some parting thoughts or recommendations, and also talk about sort of sum up some of their last messages to the attendees and other people that will be watching this afterwards about the way forward. So policy recommendations or program recommendations. And then the last question I will ask, I will respond to that specifically afterwards. I'm going to start from Mr. Ojuolape to Neha and Christine, and then Deborah, if you're still around, and then Dr. Hoops.
Doctor, I see you keep struggling with my name. Don't worry. Yes, thank you very much. It's been a good experience. I've actually learned a lot in the course of this entire conversation. But my last word will be the fact that, let me just make mention of the fact that what we have in Ghana is presently such that when we have either during the pandemic or after it, whatever we need to do, what we are doing is in a forward-looking manner to say what we are putting in place is to cater for the pandemic and also the period beyond the pandemic. So we are not looking at just something cosmetic for the time, but something that will be systemic, that will be sustainable. And that's why we have gone further beyond what we already have. Using the pandemic as the elixir, so to say. We are currently putting a system in place whereby those, if anybody calls lines and says and reports any case of sexual or gender-based violence or domestic violence, we're not just going to get the police to take care of the matter by way of investigation and prosecution, as the case may be, but we're also putting in place a system whereby the individual or those who are the receiving end, that's the survivors and and those who are suffering from the victims, so that they can get some sort of succor. So we are pre-positioning psychiatrists, legal experts, medical experts who can immediately on the spot of the moment, we can find a way to parachute help to that individual, because for me, that individual actually is much more important than the essence of prosecuting or what have you. So we are currently doing that, and it is because of the pandemic. So like they say, adversity is the mother of invention. So that's why it has gotten us, and then we believe that if we do that, it should be for the better lot of Ghanaians generally. Thank you very much.
Thank you very much, Mr. Ojuolape. Thank you. And Neha, do you have any parting words for us?
Sure. Sorry, I think I've said probably too much on this webinar, but I think I would just end with saying that, just to go back to kind of what Krista and I were talking about, that I think we know that a systematic and intentional and intersectional gender lens leads to more effective local, national, and global responses and management of outbreaks. And women's leadership and contributions are critical to sort of curbing infection rates and enabling resilience and recovery, which is something that I know is on all our minds during this pandemic. So this is also vital in conflict settings to reduce inequalities, which require special attention through hands-on exemplary leadership. And diverse, inclusive leadership, which takes both an intersectional and gender lens, should therefore be seen as a central pillar of the global response to COVID-19, particularly in countries affected by conflict. Leadership has to go beyond a position or a title, because decision-making power is critical. So I'll stop with that. Thanks. And thank you for having me.
No, thank you for joining in. Those were very useful words of advice. And Kirsten, do you have anything?
I mean, much of what Neha said, I feel the exact same, but I think one thing that's quite evident particularly through this webinar, is that, you know, there are so many shared challenges, and that we actually need to build on those moving forward, you know, to improve pandemic responses, but also responses to other crises that will continue to impact all of us. So I think it's really important to sort of, for me, obviously, it's looking at leadership, but that's leadership right across, you know, that's at local levels, grassroots, and national levels. I think it's just really important to understand that better, to support vulnerable populations in particular. So thank you.
No, thank you very much, Kirsten. And Dr. Hoops had to leave because she had patients waiting, but she said I should share this concluding message. Adolescents have unique and evolving health and healthcare needs, and they need to be considered as a special group in COVID-19 responses. They also have incredible strengths and creativity that must be recognized and amplified during this time. And she said, thank you all. And that's a very important message to leave this webinar with, because in the end, we've talked about different kinds of populations. As you said, Neha and Niyi and Kirsten, the importance of gender mainstreaming and intersectionality cannot be undermined, because it allows us to consider some of these vulnerabilities and also marginalized population in our responses, and giving them the place to speak, giving them leadership and opportunities to lead these responses and change the way we have impact, and make sure that our impact is sustainable and reaches all. So thank you all for your time, and I want to wish you all a lovely evening and weekend. And we'll be sharing information, a video about this webinar and the presentations and some of the summaries very shortly. Thank you again. Thank you.
Thank you.
Thank you.
Thanks. Bye.